Doctors, and residents of the Pediatric Dentistry Department of Universitas Airlangga. Welcome back to the second session of our Adjunct Professor Lecture Series this week. We are delighted to once again have Dr. Amol Patil, BTS MDS, with us today, presenting a lecture entitled Aesthetic Restoration for Primary Teeth. Before we begin today's lecture, I would like to invite Prof. Tania to deliver a brief welcome speech for this second session. Prof. Tania, the time is yours.
Okay, thank you, Dr. Afifa. Hello again, Dr. Amol Patil.
Hello.
Hi. So today is our fourth meeting, and it is also our final session this year with you. But although this is the last meeting for this year, I hope we will still have the opportunity to meet and collaborate again with you in the future.
Definitely.
By the
I'll be
way,
privileged.
yeah, thank you so much for the decision-making flow chart that you have shared with us a couple
Mhm.
days ago. It was very helpful. Yeah. Okay, maybe without further ado, we are very excited to hear your lecture today, and I hope today's session will run smoothly and enjoyable for everyone. Thank you,
I
Doctor.
hope I have the same. Yes. Thank you. So
Thank you,
without
Prof.
further ado, I'll also share my screen. Should I start?
Yes, you may share your screen now. The time is yours, Doctor.
Hello, everyone. So we'll start the meeting. This the chart which I shared. I hope you just keep it in your operatories or in the clinics because many a times we forget, we don't remember what needs to be done at what cases. That's the reason I shared this chart. So it becomes very helpful for everyone to go through it at the point at the time where you have a patient. You need to decide what treatment needs to be done. Just go through the chart, and it would be very easy for you to decide the treatment part. For that reason only, I shared this. Moving ahead for the today's topic, let's start the topic. So, as we all know, today's world is moving so fast. Everything is changing rapidly. Technology is evolving faster than the ever, and the digitalization has transformed healthcare as well as all the material technologies and the techniques with which the materials are being made. And this has significantly reduced the treatment time. At the same time, social media has an increased awareness of appearance, which has influenced how people perceive the smiles and the facial aesthetics, not only for the parents, but also for their kids as well. And because of this, the expectations of the dental treatment have changed dramatically for the kids as well. And because of that, there is a shift in the demand for the functional rehabilitation. Previously, it used to be just the function should be restored. Now it is not only the function, but also aesthetics should be maintained so that the patient or the child should appear good. He have a psychological benefit of looking good. For that reason, aesthetics is playing a bigger role. So modern pediatric dentistry is no longer just about saving the teeth. It's about restoring the smiles, and because of which their facial appearance and psychological benefits will also be improved, and because of which the child can also gain a confidence. So what is the importance of aesthetics in children? If the aesthetics are not maintained, what can go wrong? As per the literature, it can affect the psychology and the social aspect of the child, and because of which there can be an altered growth. It's not only because of the aesthetics, but because of the aesthetics, there is a psychological influence of that aesthetics on the child, and because of that, in the peer presence, the child might be shy while they laugh because of their anesthetic appearance, and which can lead to a altered growth of a child. It can also affect the cognitive development of the child, and these are the reasons why we need to focus on aesthetics nowadays. So, what are the major factors based on which we can decide which restorative material to choose and which one to not? So, there are three major constraining factors. First one is the child. So when we talk about the child, it's not only how the child wants his teeth to look. It's about,
Ini charger.
hello, should I continue?
Ini. Namamu juga. Enggak.
Should I continue with the presentation?
Yes, you may, please.
Okay, thank you. So the first factor is child. In case of a child, we need to decide the restoration based on child's cooperation plus the environment in which we are treating that child. Is it a chair set or a full mouth rehabilitation under general anesthesia, based on which we can decide which restorative material to choose for that child. So this is about uh, the constraining factor child. Second one is the dentist. Now, when we talk about the dentist or us, we also need to decide based on the isolation. Are we able to maintain the isolation? Because certain restorative materials like zirconia crowns, they should be luted with the resin cement. When we are talking about resin cement, or also in cases of strip crowns, they are also technique sensitive. Again, in that case, if you're going to talk about the resin materials, then in that case, isolation is a must. If the isolation is not maintained, then in that case, we might need to shift to different restorative options. So that's about the dentist factor. And third one is the parent factor. When we talk about the parent factor, in Western countries, there are insurances. So most of the time, the parent factor might not come in a picture. But in Asian countries, mostly the parents don't want to pay much, or they feel the fees is very high. So in that cases, again, the restorative options will change. So these are the major constraining factors based on which we need to decide which aesthetic restorative material should be chosen for that specific patient. So what are the challenges? Like this, early childhood caries in the initial stages, uh, or else the cases of rampant caries or severely decayed teeth. So all of these cases, we need to decide the restorative options. Either we are going to go ahead only with the restorative material like composites or with the crowns. And when we talk about the crowns, there are again different aspects of the crowns or different materials which are there. So to choose about different restorations or the crowns. Now, there is again a question about what, why, and how. So what means what type of restoration we're going to choose. Now, because of the advent of the technology, there are possibilities of 3D printed restorations or indirect restorations. Are we going to go ahead with that or with the direct restorations? Then again, we need to talk about, if you're going to talk about minimal invasive options, then is indirect restoration a minimal invasive option or a crown? So why will again come in this question and how we are going to do that? So all of these questions is going to be answered in the subsequent slides. We're going to talk about multiple treatment options from invasive options to minimally invasive options and which one to choose in which clinical scenario. So moving ahead with the treatment options. For example, if we have applied silver diamine fluoride to the patient, then in that case, are we going to mask it with the Bioflex crowns or with the zirconia crowns? Which one should we are going to opt? So that treatment decision will be based on the uh, different perspectives or different options. We are going to talk about that. So first we'll talk about the evolution of the crowns. Like in 1950s, stainless steel crowns were introduced by Humphrey. Post that, around after 40 years later, pre-Wiener crowns were launched in 1989. So the problem with the pre-Wiener crown was these crowns were bulkier. Secondly, because they were layered, there was dislodgement of the vineyard or the layer of the composite which was laid on the crown, and because of which there were multiple failures. So the different treatment objective or aesthetic alternative were thought of. Then strip crowns came in the picture. Again, strip crowns, the problem with the strip crowns was they were technique sensitive, so isolation is a must as it's a resin material. Secondly, discoloration is one of the biggest issue, and plaque accumulation, also the wear. So because of which, in 2008, almost 50 years later, since the stainless steel crowns were launched, zirconia crowns for the pediatric patients were launched. Now, Zirconia crowns were aesthetic, plaque accumulation was less. The only problem with the zirconia crown was too much of the or aggressive preparation or butchering of the gingiva was required, and because of which minimal invasive options were thought of. In around 2018-2019, Figaro crowns, the first flexible crown, was launched, but it didn't go well. The reason being there was too much wear of the crown, and within first 6 months, the crown was showing a wear of the tooth structure or wear of the material, and because of which it was discontinued from the market. In 2021, another flexible crown came in the market, that was Bioflex crown, which was introduced by Kirsi Dental Company, and it was invented by Dr. Mukul Jain. It's still in the market. There are clinical trials going on in these crowns, and they have certain in vitro and in vivo clinical trials going on, plus the literature available, which states that these crowns are pretty stable in the oral cavity. And at least for 3 year follow-up or 4 year follow-ups are showing that this crown can be used in the oral cavity. Recently, 2023 and 2024, everyone is shifting towards 3D printed crowns or resin crowns, like Revive crowns. These are launched, not commercially launched yet, but these are available in the market since 2026. These are resin crowns, resin ceramic reinforced composite crowns, which were launched by New Smile Company, and they have 3 to 4 months of follow-up. These are typically built under CDT code D2932. This is a commercial code which states that these are already tried and tested in the in the human beings. All white resin ceramic reinforced composite crowns, and they have universal sizes, not left and right sizes. Again, the tooth reduction required is slightly less compared to zirconia, and they are not like zirconia, they are not like bioflex. We can't crimp them, they're not flexible, and they can't be used for the Hall's crown technique. They are 3D printed resin ceramic crowns. They are metal free, plus till now, like till 4 month follow up, they have shown high plaque resistance, the fracture and wear resistance. One of the doctor, that is Dr. Matt, he states that the rival zirconia, they are like rival to zirconia in aesthetics while requiring a more simple and less aggressive preparation. There is no much data available about that crown. So talking about the crowns which are there in the market right now are stainless steel crowns, strip crowns, zirconia crowns, and bioflex crowns. When we talk about stainless steel crown, aesthetics is a major concern. Secondly, the another factor which comes in picture is risk of allergy and metal release, which is evident with the stainless steel crown. When we talk about the strip crowns, the durability is low, plus the tooth reduction required is minimal, but again, patient satisfaction is moderate as they can stain. There is high amount of plaque accumulation, and where of the restoration is again high, because of which strip crowns are again not most widely used. So when we talk about aesthetic restoration, most commonly used restorations right now in the market are zirconia crowns and biflex crowns. We're going to talk about these two crowns in detail. So we had talked about this. So out of stainless steel, zirconia and bioflex, we're going to focus on zirconia and bioflex. As we have already discussed, in case of stainless steel crown, they have a risk of corrosion, nickel release, and presence of heavy metals like iron, chromium, and nickel, which are cytotoxic to the DNA, and because of which everyone is thinking about another treatment options or what next or which other restorative material is ideal or feasible. I have already spoken about the Figaro crowns. Figaro crowns were launched in 2018. There were multiple trials carried out on this with these crowns. Like the trial was carried out in 2019 with a 6 month follow-up. Sorry, 2020, about 6 month follow-up comparing Figaro crowns with the metal crowns. And within 6 months, the Figaro crowns have shown deterioration. In the same year, when one more clinical trial was carried out comparing zirconia crowns with the Figaro crowns. Again, they stated that Figaro crowns did not last more than 6 months of time period, because of which they are out of the market right now. We talk about the zirconia crown. There is n number of articles which are available in the uh, on the websites, which states that zirconia crowns are a promising alternative to all the other type of restorative materials and the crowns in the field of dentistry, and they have a great deal of satisfaction and the parental satisfaction. So, talking about the zirconia crowns, uh, let's discuss this case. So, this was a 3-year-old patient who visited to my OPD. The chief complaint was rampant caries. There were multiple abscesses associated with the patient. So, we decided to plan general anesthesia. So, under general anesthesia, the treatment was carried out. Multiple pulp therapies, uh, pulpotomies were carried out, followed by the restorations and the zirconia crowns. So the patient is doing fine. This restoration is still intact. We need, in this patient, because of the abscess, 5-1 and 6-1, the anterior teeth were extracted. We have a 6-month follow-up right now. This is the second case where we have almost 2 to 3 years of follow-up with the zirconia crowns. Durability is significant. Plaque accumulation is minimal. Aesthetics are pretty well accepted by the patients. The only concern with the zirconia crowns is opposing tooth wear plus aggressive preparation, which is required. So when we talk about these crowns, when we are going to do these crowns, the chair side time will increase because of the aggressive preparation required for the zirconia crowns. We need to go at least 2 subgingivally, which can hamper the biological width, even though it's not going to cause any problem in the pediatric patients, but still, because of which healing will take at least a week's time. Post that, if there is opposing restoration, then in that like composite restoration, then in that case the zirconia crown can cause a wear of opposing restoration. In certain cases, it has shown that zirconia crown can also cause the wear of opposing tooth. So this is a follow of the same patient. This is the case 3. Now I'm going to talk about what are the problems which we can face when we do zirconia crown. Like in this case, if you see the 5-2, tooth number 5-2, or the lateral incisor on the right side, it is grossly destructed. It was restored. All of these teeth were restored with the zirconia crown. Now, when we do restorations with the zirconia crown in such badly decayed teeth, where the crown is up to CJ, then in that case, what we need to do is, in these cases, we need to remove at least 2 of the obturating material from the canals. Now, like in this case, the tooth was obturated. Post obturation, the just a minute, I have an issue. So, post obturation, at least 2 of the obturating material was removed up to the CEJ, and then GIC core was used to restore this tooth. Like GIC core was placed inside the canal 2 up to the CEJ, and the 2 of the GIC was outside the CEJ, like in the oral cavity. Post that, the tooth was prepared and then the crown was cemented. So in such cases, we can do zirconia crowns. The only thing is we need to maintain that GIC core inside. So 4 the core, 2 inside up to the CEJ, 2 outside. There are multiple other options like omega loops or fiber post. You can use that as well. The only thing over here is that post should not go beyond the CEJ when it is placed intracanal. If the post is going beyond the CEJ, then in that case, resorption of that tooth becomes a problem, and the succeeding tooth might not erupt in the same direction, it will erupt ectopically. For that reason, the GIC core or a fiber post should go up to 2 of the CAJ, 2 outside in the oral cavity. Then we can prepare the tooth and we can cement the zirconia crown. This is the major concern with the zirconia crown. So this is how we can tackle it. This was a pre-op picture, immediate post-op. This is the another thing which we need to make sure of when we're doing zirconia crown is these are passive fit crowns. They don't have snug fit or a snap fit. So when we place zirconia crowns, we cannot tell the patient to bite on it. If we're telling the patient to bite on it, there is a chance of crown fracture. Another thing is when we cement it, we need to hold the crown in the oral cavity with the tooth so as to maintain the symmetry. Like in these pictures, you can see. If you're not going to hold the crowns nicely, then there will be a slight deviation. Like in the previous case, you must have seen the 5-1 was slightly extruded. So this should not happen. For that reason, during cementation, we need to be cautious. So the trick over here is when we cement these crowns, cement two crowns at a time. Like either you can cement the crowns on the right side first and then on the left side, or else 5-1-6-1 at one point of time, then 5-2-6-2 later on. So in that manner, we can hold all the teeth nicely and maintaining the symmetry of the teeth lingually also. So whenever the symmetry is maintained, the chances of dislodgement of the crown, these crowns is less. As the tooth preparation is too much or aggressive, when the crown is placed perfectly in the center of the tooth, or when the path of insertion is correct, then in that case, the chances of crown loss are pretty less. Now, again, one more case where patient's age was around 3.54 years. They visited with the multiple caries teeth. Patient was Frankel's definitely negative. She was non-cooperative, non-sitting on the chair. So we planned the treatment with general anesthesia. These are the preoperative pictures of the child. Almost all the teeth were grossly decayed. This was her lower arch, and this was her upper arch, occlusal view. So, under isolation, multiple pulp therapies were carried out, pulpectomies, pulpotomies. Post that, crown selection was done. This was immediate post-op picture in the operation theater, where we can see all the six, like from canine to canine, all the teeth were restored with the zirconia, and the posterior teeth were restored with the biflex crowns. Now, the problem which happened in this case, this was the 1 month follow-up picture. And this is 1 year follow-up. Patient did not report for a year, and when they report, we notice that her lateral incisors, the crowns placed on the lateral incisors were missing. When we asked, they said after 6 or 8 months, she was eating a biscuit and the crown fell down. So the crown should not get loosened so easily. The problem which was there was, in this case, if you see these lateral incisors, they were grossly destructed, and the healthy dentine was not present. The crown, the tooth structure was already till CEJ and it was carious. So even though we restored this tooth in the same manner, like 2 mm of the GIC core was placed up to the CEJ intracanal and 2 mm of the GIC was outside the canal. We prepared it and placed the crown. But the problem which was there in this case was the tooth structure, the demineralized dentine was too much. In such cases, it is better not to place zirconia crowns. If the healthy enamel and dentine is not present on this near the CEJ, then that crown or tooth is not going to get retained. So because of which those zirconia crowns were lost. The purpose of showing this case was many a times we come across such cases, but we need to decide based on several factors which crowns to use and which one to not. I might have used biflex crowns in this case, but the patient wanted an aesthetic crown in the anterior region, because of which I chose zirconia crowns from canine to canine and biflex crowns posteriorly. So during follow-up, again, we saw the root were resorbing, other teeth were doing fine, certain pulpotomies and certain pulpectomies were carried out, followed by the zirconia and the biflex crowns. This was our occlusion. We needed, later on, we extracted both the laterals and Gropus appliance was given. This is one more interesting case where the lower left D and E were carious, that is tooth number 74 and 75. Post pulp therapy, on one tooth, biflex crown was given and one tooth, zirconia crown was given. If you can notice over here, the first primary molar was biflex crown and the second primary molar was zirconia crown. So radiographically, as we all know, biflex crown is radiolucent, whereas zirconia crown is radio opaque. That's the reason in the second radiograph we can see that there is just a shadow of the margin of the crown which is seen on the first primary molar, whereas on the second primary molar we can see the radio opaque tooth structure, that is zirconia crown. So again, one more factor which we need to consider while deciding a crown is if you're going to carry out a vital pulse therapy procedure, then in that case it is better to use a bioflex crown as compared to zirconia crown. The reason being, as bioflex crowns are radiolucent, it is very much easier for us to, during the follow-ups, to check the status of the pulp, to check the condition of the white. Just excuse me, I'm just having a water. Sorry for that. So in such cases, it is better to check the treatment which was carried out on that multiple therapy procedure which was carried out. It is easier to see through bioflex crowns than through the zirconia crowns. These are the post follow-up pictures of the zirconia and bioflex crowns of this patient. 6-month follow-up. This is 1 year follow-up. Now, during 1 year follow-up, what we did was just to check the plaque accumulation on the teeth, we placed the plaque ID, tri-plaque ID. And on the tri-plaque ID, what we have seen is the plaque accumulation with the biflex crown is much more as compared to the zirconia crown. It was comparatively equal to the natural tooth, but it is more compared to the zirconia crown. So when you see this second picture, the plaque accumulation on the canine, that's a normal natural tooth, is more as compared to the biflex crown, but it is more as compared to the zirconia crowns. So that's again a constraining factor or deciding factor. If the patient is not going to maintain their oral hygiene, again in that case, zirconia crown is a better option. These are the follow-up pictures of the same patient. So going ahead with the biflex crowns are nothing but resin modified hybrid crowns. And these crowns, as stated by the company, they have a tooth preparation equal to the stainless steel crown, and aesthetics is pretty equal to the zirconia crown, though not matching to the tooth color, but it is equal to the tooth color restoration. These crowns were developed by Dr. Mukul Jain in 2021, and they have a partnership with New Smile Crowns. So the crowns are being made in India and they are transported to USA for sale. So the composition is they have high impact hybrid radiopaque polymer resin. They are BCMA free, biocompatible crowns. The strength, durability, and flexibility is already tried and tested with the in vitro and in vivo trials. They have a flex fit, they're durable. There are in vitro trials carried out which states that they can occlude of up to 18 newtons, and they have tried it in the achieving simulation machines. They are aesthetic and they can be cemented with either type 1 GIC, that is luting GIC, or RM GIC. There is a change in the fitting of these crowns. They don't have active fit, that is snug fit, but they have a snap fit, which is a flex fit. Now, what is the difference between the snug fit and the snap fit? All of us have done stylistic crowns, and we have heard the sound of snug fit, which comes when the crown is moved buccally below that highest point of contour, the tooth. But in the case of bioflex crowns, we might not hear that sound because they are like when we wear a shoes, it's not completely active, but it's not passive as well. It's fits in like a snap fit. So that's a snap fit. So that type of fit is present with the bioflex crown because these crowns are flexible. They can be slightly moved apart when you're going to place it on the crown and on the tooth, because of which they have a snap fit, not a snug fit. Again, they are easy to fit. Their dimensions are occlusally, the thickness of the crown is around 0.6 and proximally around 0.3 and cervically around 0.2. So it is pretty less as compared to the zirconia crown. And when we compare it with the stainless steel crown, in case of stainless steel crown, the occlusal height is around 0.2, proximally it is 0.15 and around 0.2 near the cervical part. So occlusally, the thickness of the crown is more as compared to the stainless steel crown. These are the exact dimensions which we measured and compared with the stainless steel crown. So around zero point 0.1 to zero point 0.4 mm the difference is present with the stainless steel and the Biflex crowns. They are recently they have come up with the narrow Biflex crowns as well. These are beneficial in the cases of multiple caries teeth or adjacent caries teeth. In that cases, already because of the adjacent caries, the arch width has decreased prominently. And in that cases, if we try to fit a normal crown, it will not fit. For that reason, narrow crowns are introduced recently. What are the indications? Most commonly fractured teeth, hypoplastic teeth, restoration of the decayed teeth, and the patients with concern of aesthetics. Contraindications, the patient has a habit of bruxism or clenching, then it's a complete no. Because I have certain cases where I have seen wear of this Biflex crowns because they are made up of the high grade resin. There is high possibility of wear of these crowns if you're going to give it to the patients who have a clenching habit. Also, they are contraindicated in the cases of if you're planning to do a Hall's technique with these crowns. Then cases requiring crimping or significant crown contouring, again, this is contraindication. In the cases where there is severe space loss or inadequate tooth structure for the proper retention, again, these crowns cannot be used. When we compare these crowns with the zirconia crowns again have a high polished surface because of the ceramic surface, because of which there is low surface roughness, and because of the low surface roughness, there is low surface energy, and which can lead to lower plaque accumulation. Because of that, gingival health is better with the zirconia crowns as compared to the Bioflex crowns. Also, in case of zirconia crowns, there is no need for the crimping and contouring. They are prefabricated, they have a passive fit. Whereas in the cases of Biflex crowns, as they are polymer resins, so there are certain limitations in the finish and polish, and because of which, over a period of time, they can stain. The plaque accumulation is more, and the chances of wear are also there if you're going to give it in the patient, if you're going to keep it high in occlusion or in the patients where they have a clenching habits. So this is the in vitro trial which is recently published in pediatric dentistry, where we tested three different crowns which are most commonly used in today's times, that is stainless steel crowns, Biflex crowns, and zirconia crowns. So we did a chewing simulation on all of these crowns. The chewing simulation is mimicking around 5 years of chewing in the oral cavity. So that's what was done in this chewing simulation, where we placed these crowns in the incubator chamber where saliva was used as a media, and opposing to these crowns there was a tooth structure which was placed, which was continuously running in the motion. So it was mimicking around 5 years of chewing in the oral cavity. And the results what we achieved was Biflex crowns demonstrated high in vitro values of wear resistance, but their relatively recent introduction into pediatric dentistry warrants caution. So when we are using them, we need a substantial data. Right now, we only have 2 to 3 years of data and certain clinical trials and certain in vitro trials, which are stating it is good. But still, a long-term clinical trial is required, because a robust long-term clinical trial will determine are these crowns going to last or not. There are multiple clinical trials done in 2024 by Dr. Latha, Dr. Devlikar, then by Dr. Singh in 2025, then Ninave. There was one significant publication which was done in 2025, Dr. Valley. She stated that conventional GIC gave the best performance, followed by resin cement when we used as a cementing media for Biflex crowns. Because they are opaque crowns, curing is not possible, and because of which RMGIC is not giving better results when we use this as a cementing media as compared to conventional GIC. These are some more clinical trials which are suggesting Biflex crown is a better option, better alternative to other treatment options. In 2024, I also published one of the clinical trials comparing around 12 parameters, which again suggested a long-term clinical trial is required, because in our trial, what we found is where was seen in certain cases where the crown was placed a little bit high in occlusion. Also, plaque accumulation was a major concern with the Biflex crown, even though the company is coming up with the newer generation of the crowns, which is highly polished. So this was a publication which was stating the similar thing. It is giving similar results as compared to zirconia and stainless steel crown in tooth preparations and aesthetics comparatively. But again, a caution is required because still we don't have long-term follow-ups. It was just a one-year follow-up. So, what is the difference in the tooth preparation? When we prepare zirconia crowns, we need to go subgingivally. Always, in case of preform crowns, either it may be stainless steel crown, zirconia crown, or a biflex crown. The margin should be feather edge, not a chamfer, not a bevel, or not a ledge. It should be feather edge margin. But what we need to be make sure is that when we prepare the tooth occlusally first, so that when we prepare the tooth proximally, there is little bit of the tooth structure which is remaining. So chances of adjacent tooth trauma are less. Secondly, first prepare the tooth supragingivally, then go subgingivally. In that case, bleeding will be minimal because we are hampering little bit of biological width, not more. So always prepare the tooth occlusally first, then proximally. That too, again, prepare the tooth supragingivally first, then go subgingivally, so as to minimize the tissue destruction. One more difference as compared to stainless steel crown with the biflex crown is we need to prepare biflex crowns from the buccal aspect as well. The red spot which you see on that tooth model is the hot spot, or it's called as the sweet potato spot. It's the highest point of contour of the tooth. So that part should be prepared at least 0.5 to 1 mm when we place a biflex crown. Otherwise, the crown will not seat. In case of stainless steel crown, we prepare the tooth 1.5 mm occlusally, just reduce the proximal areas to reduce the contact point and we seat the crown. But in the case of biflex crowns, we need to reduce the occlusal part 1.5 mm, buccally and lingually as well, at least 0.5 to 1 mm, and then proximally reduce the contact points, and then you can place the biflex crowns. Moving ahead with the tooth preparation. So first will be occlusal reduction, then proximal and buccal and lingual reduction, followed by beveling and finishing and polishing. So when we prepare the occlusal tooth part, it should be 1 to 1.5 mm. Followed by that, we need to move on to buccal and the lingual preparation because there are highest points of contour on the buccal and the lingual aspects. In case of lower molars, this highest point of contours are present on the buccal aspect, whereas in the case of upper molars or maxillary molars, this highest point of contours are present on the parietal aspects. Proximally, 0.5 mm reduction is required so as to reduce the contact with the adjacent tooth. Then round off all the line angles and the point angles. Followed by that, to leave buccal and the lingual convexities, but may need to do some reduction in the buccal bulge. So these are the bulges which can cause a problem while seating biflex crowns. This is the final test fitting. When we seat the crown, it should be seated from lingual to the buccal side. So this is a pre-op picture case courtesy by Dr. Mukul Jain. This is a pre-op picture of the tooth, then tooth preparation, and this is the final fitting of the crown. So this is the 6 month follow-up. In the 6 month follow-up only we can see these dimples. So as these crowns are made up of the hybrid resin, they show some dimples on the crowns. So this is the self-adjustment of the crown according to the occlusal forces. These are the 10th month follow-up pictures. Again, in the cases where there is a application of a silver diamond fluoride, instead of using zirconia crowns, biflex crown is a better option as tooth preparation required is minimum. Secondly, these crowns are radio opaque, so that radiolucency of the SDF will not be reflected through these crowns. Zirconia crowns are translucent, so when we apply zirconia crowns in the cases where the silver diamond fluoride was used, then that translucency will be reflected, or that black color will be reflected through the zirconia crowns. So this is a short video which states that how to prepare a tooth for biflex crowns. So occlusal preparation with the football shaper, preparing the grooves on the occlusal surface around 1 to 1.5 mm. Uh, I don't want to waste time on the video. I'll just share this video with you all later on. So I'll just go ahead with the presentation because too much part of the presentation is still remaining. So if I may, should I move ahead or do you all want to see this video?
You may please go ahead, doctor, because we have a limit.
Okay, thank you. So when we check the occlusion, we can reduce these crowns, we can trim these crowns. So when we place these crowns in the oral cavity, we can use a scaler just to check if there is any blanching. Mark that part with the scaler. Post that, we can either cut this crown with the scissor or we can trim these crowns with the green stones. So this is not possible with the zirconia crowns, but because these crowns are hybrid resins crowns, we can do that. Crimping and contouring is not possible. And during cementation, we can tell the patient to bite on it. As these are snap fit, it can fit nicely in the oral cavity. So I'm just going to show you some of the cases of the biflex crowns. So this was the patient of my clinical trial, which I published. So in that trial, we did a split mouth study where on one side stainless steel crown was placed, on the other contralateral side, biflex crown was placed. So these were the preoperative pictures of the same patient. The crowns were placed under isolation for that clinical trial. So this is the preparation which is required around 1.5 mm all around. This is the final preparation and occlusion, intraoperative pictures, post trimming and contouring. These are the post operative pictures of that patient. We continue to do the trial, follow up that patient for a year, and post that we publish the trials. This is the second case again, same thing that from the clinical trial where on one side stainless steel crowns were placed, on the other side biflex were placed. During the follow-up, we again saw the dimples created on the biflex crowns. This is because of the occlusal stresses. The crown was getting adjusted. And on plaque accumulation, what we found is the plaque accumulation was more with the biflex crowns as compared to stainless steel crowns. So now in this case, we found an interesting thing. The patient came with a complaint of pain with the upper right first primary molar. So on one side, we did restoration with the crown, and on the other side, pulp therapy with the crown, and both the sides bioflex crowns were placed. So these are prototype bioflex crowns. We continue to follow up this case. During follow-up, this is 1.5-year follow-up. There were just dimples created on the crowns. Both the crowns were placed at the same time. During around 2-year follow-up, what we found is on one side, the crown was showing wear, and on the other side, the crown was as it is. Even though the crown was wear placed at the same point of time, second, the occlusion was maintained on the both the sides. Still, we did not understand why the crown showed wear on one side and on the other side, the crown was as it is. Uh, we continued to follow up this case for 3 years, and then post 3 years, what we understood is the succeeding tooth were erupting. So almost the wear was there, but the treatment objective was achieved. Like succeeding teeth were erupting, and for that reason, later on we extracted that D and gave the space for the premolars to erupt. So there is a chance of wear with these bioflex crowns. This is one more case with 2.5-year follow-up. Initially, the patient visited with rampant caries. Certain teeth were extracted. Followed by that, a non-metal arch pacemaker was given. Again, this was a patient from the trial. That's the reason on one side Bioflex crown was placed, on the quadrilateral side stainless steel crown was placed. Uh, then the patient was followed up for a year. Post that, we shifted that nasal arch from east to the first permanent molars. Initially, the first permanent molars were not erupted, and because of that reason, the nasal arch was given on east. Post that, on the first permanent molars, the transmural arch pacemaker was given just to maintain the arch width of that patient, because patient had a deep palate. For that reason, the transmural arch pacemaker was given. This is the 2 year follow-up, and still the patient has a good occlusion. There is no wear of the crown on both the sides. But concern with this patient was a plaque. If you see in the first picture, plaque is more with the biflex crown as compared to the stainless steel crown. So not only for the molars, they can be used for the anteriors as well, even though the aesthetics is not as good as compared to the zirconia crowns. But still it is possible that we can use these crowns for the anterior teeth, and certain patients will accept that. If you are going to use these crowns for all anteriors, like all four anteriors, then it will not look that bad. They are opaque, they cannot be made more translucent. For that reason, it looks different as compared to the natural tooth. Again, in this case, we followed up this case until the exfoliation of the anteriors for up to almost 3.5 years. There was no wear. And if you can see in this picture, the central incisor is erupting now. Radiographically, you can also see the treatment goal is achieved. This crown have lasted till the exfoliation. So for the anteriors, till now, I have not seen any kind of wear. But for the posteriors, after 2.5 years to 3 years, I have seen a wear in these crowns. This is one more case with the anterior, like grossly destructed upper anteriors. Now, I have shown you one failure case of zirconia crown where if the tooth is grossly destructed and if the carious part or the dentin is present up to the CEJ, then in that case, retention becomes a problem with the zirconia crowns. But in this case, as these are flex fit crowns, as the preparation required is minimum as compared to zirconia crowns, in the cases where the tooth structure is like this, like there is no tooth structure available with the 5-1 and the 6-1, still we can restore, like obviously post endodontic therapy, tooth was restored again with the GIC core only, 2 mm subgingival, 2 mm supragingival, and these crowns will last more as compared to zirconia crowns. What I experienced. So this is my experience that in such cases, better to go ahead with the bioflex crowns if the patient is agreeing to the aesthetics which is provided with the bioflex crowns. So these are the follow-up pictures of this patient. Till now, there is no dislodgement of the crown. Also, we can use these crowns for the permanent molars as well. They have a separate kit for the permanent molars. I have a follow-up of up to 1 to 1.5 year for the bioflex crowns given on the permanent molars. For the permanent molars, the occlusal thickness is much more. It's not limited to zero point 0.6, it's around 0.8. And because of that, wear is still now not seen or not evident with the bioflex crowns, which are given on the first permanent molars. So in the cases where the patient have hypoplasia, like hypoplastic molars, MIH. So in that cases, this is a better option if the patient wants an aesthetic restoration. Otherwise, stainless steel crowns are the gold standard. So this was the same patient who had molar incisor hypomineralization. So almost all the cells were restored. Lower left 6 was restored with the composite restoration, whereas all the three other 6s were restored with the endodontic therapy followed by bioflex crowns. We have seen dimples on these permanent molar biflex crowns, but nowhere is evident till now. For the anterior canines, the problem which I have seen, if you're going to give this biflex crowns opposing to the tooth which is in contact or opposing to the crown which is in contact, then again, as these are raising crowns, you can see a wear. Like in this lower canine, both of these teeth, both of these canines were restored with the biflex crown. But because of the pressure exerted by the upper crown on the lower crown, you can see the wear on the lower canine. So this is possible. This is seen on the crowns. So be cautious when you give these crowns. It should not be in the occlusion. or not hampering the opposing tooth. This is one more case where all the 19, all the 20 teeth were treated, but all the 19 teeth were crowned with the Bioflex crowns. One tooth needed to be extracted because of an abscess and root resorption. So these are the pre-op pictures of this patient, and this is the crown. So this was done chairside. As tooth preparation is minimal, it is possible to do it chairside. Whereas if it could have been a zirconia case, it would have been a nightmare for me, because preparation of the tooth is pretty much in case of zirconia crowns. So again, a 3.5-year-old man nicely managed with the biflex crowns. All into 20 teeth were restored with the biflex crowns. But the major concern which I have with the biflex crown is a plaque. Like you can see in this case as well. During the follow-ups, the patient complains of only one thing, like, doctor, how much ever I brush, there is a plaque on the tooth. So that thing is there with the biflex crown. So for that reason, be cautious when providing it to the patient who can't maintain their oral hygiene. It is no for those patients. Chair side, it is very easy to do under the sedation. One more option I'm going to talk about today is indirect restorations. As digital dentistry is advancing, as there is one more 3D printed crown which is coming up in the market with the new smile. It's again a resin restorations. Likewise, indirect restoration is one of the options. I'm carrying out one of the clinical trial with one of my postgraduate student as a thesis, where we are trying to use indirect restoration as aesthetic alternative to the crowns. We're comparing it with the Bioflex and the zirconia crowns, where class 1 restorations and class 2 restorations were done with the indirect composites. Post scanning, chair side, chair side, we can lute this indirect restorations on the tooth. We have a follow of almost 6 months right now, 6 months to a year. And till now, there is no dislodgement, no wear through. Again, plaque accumulation is less as compared to strip crowns or biflex crowns. The reason being these are high grade resins, indirect resins, which are highly polished. So because of which there is no plaque accumulation on these restorations, and wear through is also not evident. As these are raising materials, radiographically you can't see them. So this is the pre-op and the post-op picture, post indirect restoration. Uh, Radiographically, it's not visible. It's the second case. Patient's name is Varnika Chaudhary. She's 5 year old, tooth number 85. Again, an indirect restoration was placed. So there is a protocol which we need to follow. Like we need to use hydrofluoric acid for the etching of the restoration as well as the tooth. Then we need to apply a monobond on the restoration as well as the tooth. There are multiple steps involved, but it can be done chair side. If you have a scanner in your operatories, it is very easy. Just the scanner and 3D printer is required. Within an hour, we can give the restoration to the patient. Uh, so these are the post-op occlusion pictures and the follow-up pictures. This is a 6 month follow up which we have right now. We are still following it up till 1 to 1.5 year, and post that we might publish it as well. Because till now we have not seen any problems with this indirect restorations, neither the wear, nor the dislodgement, nor the plaque accumulation. So let's summarize the options what we have based on the evidence. There are multiple treatment options which we can think of, but to decide between the different restorative options like stainless, either to go ahead with the stainless steel crown, zirconia crown, biflex crown, or indirect restoration. First of all, the step one is indication for the full coverage restoration. Is it indicated for the full coverage restoration or just the restoration? Based on that, you can decide either to go ahead with the restoration or a crown. Because if the tooth structure is minimally involved, then in that case, indirect restoration is a better option. It's a minimally invasive option. But if the tooth is grossly destructed, mutilated, then in that cases, we can think of the crown as an option. Like multi-surface caries, post-pulp therapies. Even in the case of post-pulp therapies, if the cavity is class 1, then I prefer, or what I think is, we can go ahead with the indirect restorations. In the cases where there are developmental defects like patients with MIH hypoplasia, or when there is a chance of fracture or high caries risk, go ahead with the crowns instead of going ahead with the indirect restorations. That's what is my take. Secondly, for the anteriors, if the patient demands aesthetic restoration highly, then in that case, there is no other alternative than zirconia because it is the best. Bioflex, certain patients might accept it, certain patients might complain about it because it can have a plaque accumulation which is pretty more compared to zirconia, but preparation is minimal as compared to zirconia crowns. When we talk about posterior crowns, first we need to assess the structural integrity of the tooth occlusion. If there is crossbite, it's a contraindication to give a crown. First we need to correct the crossbite, then we can provide a crown. Then we also need to think of longevity options. Like if the patient has clenching habits or any other habits, based on that, we can decide to go ahead with the stainless steel crown, biflex crown, or a zirconia crown. As biflex crown is not an option in the cases where patient has a clenching habit. Then, if the remaining tooth structure is minimal, it has thin walls, extensive coronal destruction, the stainless steel crown is a better option if the patient does not want aesthetic restoration because it can be crimped nicely. If there are mild undercuts, limited occlusal clearance, then in that cases, the aesthetic alternative option is biflex crown. If the patient has high aesthetic demand in posterior as well, zirconia crown is the best option. If the patient has poor cooperation, moisture control is an issue, then again zirconia crowns cannot be given because when we are going to restore zirconia crowns, if you're going to cement it, resin based cement should be used to have a highest durability. Otherwise, if you're going to use a luting, type 1 GIC luting, then chances of dislodgement are more with the zirconia crown. And for that reason, if the patient does not have a cooperation or moisture control cannot be there, then instead of going ahead with the zirconia, we can go ahead with the stainless steel crown because it is less technique sensitive and it can be luted nicely with the type 1 GIC. In the cases with bruxism, high occlusal load, stainless steel crown and zirconia are the option. And for the indirect restoration, it's a minimal invasive option which can be used in class 1 or class 2 cavities. It cannot be used with the opposing zirconia crown because it can cause a wear of the indirect restoration. That is what is possible because zirconia crown can cause a wear of opposing tooth structure as well. This is a resin restoration, indirect restoration. So it can also wear through. Till now, we have not seen that, but there is a possibility. So this is what is a decision algorithm, what I prefer. You can also go through it. If feasible, you can use this as a treatment option for your cases as well. Thank you so much, everyone, for your patient listening. And I'm thankful to Erlanga University to giving me an opportunity to present and to share my insights. Thank you so much. Is there any question or any
Thank you so
queries?
much, Dr. Amol Patil, for the very insightful presentation. Now we will proceed to the Q&A session for the participants. If you have any questions, you may use the raise hand feature or you can write them in the chat box, please.
Okay, we have a question. Based on your clinical experience, what factors most influence the long-term success and survival of aesthetic restorations in primary teeth, especially in pediatric patients with limited cooperation and challenging isolation conditions? So, what I prefer mostly in the cases where patient is not cooperative, isolation cannot be maintained, or patient has a limited cooperation, then in that case, stainless steel crown is a better option. But if the patient wants an aesthetic restoration in that case, then I will go ahead with the biflex crown as compared to zirconia crown because already patient is uncooperative, we cannot maintain the isolation. So so in that cases, if you're going to go ahead with the zirconia crowns, it will be challenging for the dentist as well as for the patient because patient might need to sit in the dental chair for long duration of time as the preparation required is much. Secondly, it's aggressive preparation which can cause a lot of bleeding. Patients' parents can also get anxious because of that. Thirdly, after a while, dentists will also get fed up if the patient is not cooperating and we need to prepare the tooth and cement it with a resin-based cement. If the isolation is not maintained, then the dislodgement is pretty evident with the zirconia crowns. So in that case, Bioflex crown is a better option as we can lute it nicely with the type 1 GIC. So if the isolation is not possible, patient is not cooperative, then minimal invasive option is Bioflex crowns. And in such cases, if you want to go ahead with more minimally invasive options like indirect restoration, then in that case, uh, the cavity should be either class 1 or class 2. If the cavity is class 6 or MOD cavity, then in that cases, the chances of dislodgement of indirect restoration are also very high. So, based on your question, Bioflex crown is a better option for such patients who are less cooperative, isolation is an issue, and they want an aesthetic restoration, then Bioflex crown is an option. Okay, the next question is how deep should the GIC or omega loop extend during core buildup preparation in primary teeth? So it should be at least 2 mm up to the CJ. If possible, I can just try and draw it. So I'll just try and draw it. For example, this is the anterior tooth. Now, in this case, the tooth is already destructed up to the CJ. Then in that case, we are going to put the core. So, for example, this tooth is broken till the CEJ level. Then in that case, remove all the caries, enamel and dentin first. First of all, remove all the caries part. Otherwise, the GIC is also not going to bond to the caries tooth structure. First, remove all the caries part. Post that, that GIC core or omega loop should be placed at least 2 mm subgingivally, CEJ, and 2 mm supragingivally. So, for example, this is the CEJ level. Then it should be 2 mm, 2 mm subgingivally, 2 mm supragingivally. Then only it will have the strength to hold the crown structure. Otherwise, it cannot hold the crown structure. So it should be 2 mm subgingivally, 2 mm supragingivally. Post that, you can prepare this nicely and salute the crown. Hope this answers the question. And when you use omega loop or stainless steel wires, then in that case, again, there is a possibility or a chance of retention failure because it's a metal bonding with the GIC. It is better to use GIC as a core buildup or a fiber post as compared to omega loop because omega loop is a metal. There is again an interface which is getting created between the metal and the luting cement and which can cause a bond failure. And for that reason, it is better to use GIC core because GIC can easily get attached with the luting GIC. So that strength will be better. There is no interface of metal and other restorative material. So instead of using omega loop, prefer a GIC core. That is what I prefer. Hope this clears the question's answer. Is there any other question? Yeah, we have one more question. Are there any specific cases in which you would not recommend crowns for primary teeth despite high aesthetic demands from the patient's parents? Yeah, definitely. In that case which I have shown, the crowns, the lateral crown, the lateral incisors were failed. Within just 6 months to a year's time span, patient reported with dislodged zirconia crowns. In such cases, it is better to go ahead with the extraction followed by the Groper's appliance, uh, like in that case and this case as well. If the caries are up to this CEJ level or below that CEJ level, and when we remove the caries, still there is carious part which is present up to the subgingival part, then it becomes very difficult for us to go subgingivally because in case of pediatric patients, we cannot do cauterization, we cannot go subgingivally by taking the gingiva below the CJ. In that cases, it becomes troublesome for the patient. Plus, we have a succeeding tooth bud, so we cannot go subgingivally too much in these cases. So in such cases, better to extract the tooth and give a gropus appliance rather than planning for the crowns. Most commonly in the anteriors, we see this because of the feeding problems or early childhood caries. The caries are below the CEJ. Whenever caries are below the CEJ, then there is no pericervical dentin remaining to hold the crown. There should be some amount of pericervical dentin present. Ideally, it should be 1 to 1.5 amount of pericervical dentin, healthy pericervical dentin present, which can hold the restoration. If that pericervical dentin is not present, then in that case, it is better to extract and go ahead with the Gropper's appliance. Gropper's appliance is nothing but we use the bands on the posterior molars, and with the help of that, we can use the uh, to to place the crowns on the to replace the crowns like a Maryland bridge in the anterior region. Hope this answers your question. Any other question?
Thank you, doctor. Any other question from the participants? If there is none, perhaps that's all, doctor. That concludes all the questions for today's session. And thank you, Dr. Amol Patil, and all of the
Thank you so
participants for
much.
the engaging discussion. We have now reached the end for our session. Before we close, we would like to invite our speaker, Dr. Amol Patil, and all the participants to take a group screenshot for documentation purpose. I would like to ask the committee to kindly assist with the screenshot. We begin with the first page. In 3, 2, 1. For the next page, 3, 2, 1. Okay, thank
Thank
you
you.
once again. On behalf of the Pediatric Dentistry Department, Universitas Airlangga, we sincerely thank Dr. Amol Patil for today's
Thank you so
enlightening
much.
presentation. Thank you. And to all the professors, doctors, and all participants joining us today, we sincerely apologize for any imperfections and thank you for your attention and participation. With this, I formally close this session. Have a great day. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you so much, everyone, for giving me an opportunity to present this. And sorry if at all something has went wrong. Like in between the sessions, I skipped that video. I'm going to post that video. I'm going to share that video with one of your students because of the time constraints. I was not able to show certain videos and certain clinical cases. So I'll make sure that I'll share that presentation with one of the participants. And sorry for any trouble or any problem in understanding if at all there is any because of the time constraints. Certain times I might need to increase the pace of my presentation. So if at all there was any issue, sorry for that, and thank you so much everyone, uh, the patient listening.
Thank you, Dr. Amol Patil,
Thank
once
you.
again. Look
Thank you.
forward to seeing you in another occasion.
Same here, same here.
Bye.
Bye. Hello, doctor. Thank you.